How do you emerge a dead patient?
You can't.
It's
Pull the tube out.
You cannot take the tube out of a dead patient. You all know that, right?
Yeah.
You know that, right?
Yes.
Okay. Are you ready?
Yeah. So
not.
patient is in maintenance.
Okay.
No,
What's your
no.
EKG look like?
I need my stuff actually. Manual.
For the sake of the exam, the maintenance, emergence, extubation, don't overcomplicate it. Take the lead, and we're going to see the emergence be the worst part, the most difficult part for you to learn. Turn your entitled O on, because you're going to need that.
Entitled what?
Oxygen. Pre-oxygenate the patient.
Bottom right.
Bottom right. Perfect.
Oh yes.
Right. The reason that I didn't say this, when you're emerging that patient, before I emerge that patient, let's say I'm using a 50-50 blend of whatever. I'm going to make sure that I turn that off, and I'm going to fully saturate that FRC prior to extubation. Just like prior to intubation, I want to have that tank full in case something happens. I again want to have that tank full in case something happens on extubation at bite time, right? And so you're going to check and know that it's full by the end-tidal oxygen. All right, so let's just do the lap chole. Anybody look up the lap chole yet?
Yeah, a little bit.
Okay. So in a laparoscopic cholecystectomy, what, you read Jaffe?
Jaffe. Yeah.
Okay. So what are some things that can happen with insufflation of the pneumoperitoneum?
You can have a bradycardia,
Okay, and why?
vagal stimulation.
Okay, good. So we'll do a mock thing here. Okay, go and lower the table so that we can, you hear the surgeon talking and they're saying things like,
Say lower.
lower the table, or Barry's needle. Okay, that's good. And you hear them start to say Barry's needle, you're thinking what? What are you thinking? Are you thinking?
They're about to insufflate.
Well, getting close, right. So what are you going to be looking for?
Make sure they're ready for.
So
Oh, you mean like we're okay?
let me start over.
Mhm,
Yeah,
yes.
I didn't give you guys enough information. So I started the case, in fact, even better. I started the case, hey Liviu, thanks for giving me lunch, or I'm going home. We just started, this is a 46-year-old male here for acute cholecystitis. They're gonna do a laparoscopic cholecystectomy, no allergies, history of alcohol, CAD, hypertension, OSA, diabetes, chronic pain use, and all that. He was an easy mask, easy intubation. Well, I did an RSI on him. He was a grade 1 view on laryngoscopy, easy intubation, switched him over, tubes in a good place. You're on a Macagas 2.0 SIVO. He's already had his antiemetics, Decadron 10. I gave a little bit of Reglan just because of the RSI. I haven't given him anything else. He's had 150 of fentanyl, 200 of pro, sucks. I gave him 150, lidocaine 100, and he had 2 of Versed out there. Antibiotics, he got 2 grams of Ancef before we came back. That's in. What else can I tell you? Anything?
Baseline of the vital signs.
Yeah.
Baseline vital signs have been rock solid right there. It came in at a rate, I think his rate was 90. You can go back and look on the trend, but blood pressure 126/82, a rate of 78. He's been great. No problems right there. That's where he's been for me.
Mhm.
What else can I tell you, brother? What else do you want to
I
know?
can see even.
Huh?
The depth of anesthesia.
Entitled CVOs 2%.
I mean, other than the fact that
No
what
twitches?
already can see, I don't know.
You don't have to ask anything. I mean, if you need something, great. If you don't, that's fine too.
Okay, so he's in maintenance. Did you give any other drugs?
That's all I've given. I just put him to sleep right
Just
now.
put him to
Just
sleep.
lowered the table. You heard them talking about they want to do the very slow.
So I'm gonna give another 50 to 100 of micrograms of fentanyl prior to incision.
Okay.
Make sure that I have that.
Okay.
If as they do that, and make sure that my entire SIVO reaches about 1.3 of MAC before incision.
We're gonna do incision like in 20 seconds or in a minute.
Oh,
Okay.
Then I would do fentanyl about 100.
You're gonna give.
If
100?
100 of 50
Okay.
to 100 of fentanyl. Make sure it's.
How much you gonna give? 50 or 100?
Prior to incision, 100.
Okay, great.
Because his blood pressure is good,
Perfect.
heart rate is good, so.
All right.
I'm
So
not
you're giving
afraid.
100. Can I leave? I gotta go. I gotta
Yes.
take my son to.
Yes.
Is that good?
Yes, sir.
Thank you. Hey, good to work with you though. See you. Appreciate it. I'm glad you joined the team. All right, so you give 100 micrograms of fentanyl. Perfect. And very sneaky. Anybody, if you want to add anything, guys, you add something too anytime you want. Okay, it can be like a little team thing here.
Is there any muscle relaxants too?
Haha, that's
Oh,
key.
yes. Oh, because that's not gonna last.
Incision.
All right. No.
Yeah, check the twitches.
Yeah, let's check the twitches before I give any further muscle relaxants.
You got some twitches.
Okay.
4 of them. 4.
Uh-oh.
Okay.
He's all the way back.
All the way back. So I'm gonna give him another. I think the procedure is like what 2.
How long does it take?
1 hour, 2
minutes?
hours.
30 to 2 hours. I think.
30 to 2 hours.
So I'm gonna give about I don't know, 50 of rock.
I like 50 rock. Okay, you giving it?
So I give 50 of rock, and I gave my fentanyl,
And you hear incision.
and I can tell the doctor you can make incision.
Sure.
Yeah.
And he'll probably fine. You have gas on. We'll say it's 1.3 MAC. That's fine. You gave some narcotics, so that should blunt some of the incisional pain for the little incision. That shouldn't be much yet, right? And by the time, thank God Garl was here to save you. Phone a friend, good job. That muscle relaxant was key, right? So we got muscle relaxant on board. You're listening for incision. What are some things you're listening for incision? And we talked about this.
Listening for incision.
No. During incision, when I say listening, guys, what I'm saying here too is I'm not necessarily listening for the surgeon. I'm listening to that monitor. Okay.
Oh,
What do you hear in the background right now?
Yeah. That's the heart rate. So
It's a heart rate.
yeah,
So incision, what would I expect if the patient was lightly anesthetized? What would I hear?
I would hear that going faster.
You would hear tachycardia. Exactly. So don't hear any tachycardia, so you must be good, right?
Yes.
All right. Can you please position the patient? We're going to try to establish a pneumo right now. So how are we going to position the patient?
First it's reverse Trendelenburg, and then afterwards.
Reverse Trendelenburg.
No, that's Trendelenburg.
Don't we turn the patient a little bit to?
So think about this. What procedure are we doing?
It's upcolon.
Okay. Where is the lap colon? Where is the colon? Where is the gallbladder?
It's on the right. So we normally have to position the patient on the left side so they can have access to.
It's in the right upper quadrant, or we'll say upper
Oh, I see.
stomach.
So you
So
do-
how would we position that? What is the positioning that we're looking for in this?
Jackknife. I don't know.
I've never seen a jackknife lap colon.
I don't know. I read in your PowerPoints.
He already that.
So you do supine.
So here's what I want to say.
And then you.
He's already been supine. Now I want to establish it. Here's what we're going to do, guys. Okay. Upper quadrant. Do I want to have the stomach contents come up, or do I want them to go away from the gallbladder? Just think about this. Think about simple anatomy to answer these questions. What do I want to...
I want them to go away from the gallbladder.
So how do I get the stomach contents to go away from the right upper quadrant? What position?
That's should be a reverse.
Left
Reverse
side.
Trendelenburg with
Left sided.
left tilt.
Yeah.
Just go and position the patient. See how easy that was? We just thought through anatomy.
How many degrees do you usually do for this?
26.7.
Okay, sounds good. Thank you.
The least amount.
Okay, that's fine.
You know how, here's a real answer. You just do a little bit, and then if they say, can I have a little more, just give them a little bit more. A little bit. That's too much. No, I'm just playing. You're good. Okay, so they're establishing the pneumoperitoneum. You hear them, they start out 5 or 6 millimeters of mercury. Okay, can we have high flow, please? When you're talking about flows like this, they're starting to talk about the pressure of the gas that they're insufflating their stomach. The stomach will start to distend. Okay? So you start to...
So it's going to be hard for my patient to breathe.
Very
so
hard
I
to
have
breathe.
to increase my pressure.
What else is going to be very hard? What's going to be going on? Is they put that intra-abdominal pressure going on. We're going to train our ear to listen to the monitor. Because we got one person that gets what's going on the monitor, and that's it.
We're going to decrease the preload.
Thank you, Carl. You could tell. You could save his life because he needs it.
Yeah, that's happening.
Oh, that's not good.
That's not good.
Sir, we're going to have to back down on that to CO2.
So I'm trying to get out of here. I got an appointment today.
Okay, my patient is...
No, so here,
bradycardic.
this is good. I'm doing this
Yes.
for a reason. As soon as you see that, is that an emergency?
It is.
That's an emergency.
Yeah.
And what's the cause of this emergency?
Too much inflation.
The pneumoperitoneum. So what do you tell them? Sir, drop the pneumo. Hey, turn the gas off. Evacuate the gas. Remember, so read the procedure. When they do this, they're going to have 3 ports in, okay? And they're going to have it connected to gas. What they can do is simply pull that port out, squeeze that gas out of the stomach, and you'll come right back out of that. The problem with the heart rate of 34, it's okay, but because you still have one. But if you get on it as low as we're going right now, that'll progress to asystole very quickly. Asystole is very hard to deal with because then you have to mechanically pump the heart. The heart's not pumping, right? So you have to be on that quickly. You caught it probably because you were seeing it. That's what I'm saying. Train your ear to hear that. When I'm talking to you that whole time, you better know your procedure.
Yes.
You better know when you're hearing this flow and stuff, you don't need to be conversating with anybody. You need to be paying attention to what's going on because you just got to emergency and you didn't even recognize it. Okay? And that's okay.
I didn't hear it. That's-
I know you didn't.
Yeah.
And that's okay. You guys will learn. So we'll say you said drop the pneumo, right?
Yeah, please drop the number, sir.
And just tell him. If he says, oh, what's going on? Just say, sir, drop. It's an emergency. And most of them know. But even if they don't, you tell him immediately, drop it. At the same time, what is something you would be doing? Your patient, let's think about this. Your patient just had a bradycardic episode with establishment of the pneumoperitoneum. You're going to cancel the case.
Not necessarily.
Try again at a lower.
You're going to try again. They're going to try lower. What's one thing that we could do to prophylact against this? It's a vagal response.
Glycopyrrolate.
Do we have
So
any?
just-
Do we have any vagolytics? Glycopyrrolate. So get some Robenol. What would you like to give Robenol or atropine? What?
John Carl.
Carl's done his homework. Carl's getting A's. I'm just saying.
Yes, I would like to give him some.
What's the dose? Now you know this because you're in anesthesia school. So what's the dose?
I didn't learn it for this procedure, but I would
But you-
probably give about 2
2 milliliters.
milliliters.
How much is 2 milliliters?
0.2 times.
Okay.
So yeah, that's 0.4. 0.04. Yeah.
0.04? 0.4.
Yes.
0.4 milligrams.
0.4.
Go ahead, silence. On your left. Okay. So a vagolytic is something that we could give, speed that heart up, and hopefully prophylax. Together, we should be able to establish a pneumo. So we're going to say that you gave that, right? And they establish a pneumo. They're doing the operation. 45 minutes has gone by. Gallbladder, you just now see the gallbladder come out. Okay, they have it in a bag. They just pull the gallbladder out. We said earlier, and you said it before this whole cardiac thing happened, but when we established the pneumo and you heard high pressure, what's another thing that we could see would be a challenge for us as the anesthesia provider and the patient with the pneumoperitoneum? What's something that
Would be hard to ventilate.
hard to ventilate? What do we do against that? And what's our indicators? What are some of the indicators, guys, that we would see it's hard to ventilate this patient?
So the lungs will be non-compliant. So then your pressures will
Your
increase.
Peak airway pressure.
peak pressure will
Peak
go
airway
up.
pressure will increase.
Okay, so we're going to start very basic with you guys. So let's say our pressure's around 30. We can live with 30. What's another thing that we can see? As pressure goes up, remember your gas laws? What about volume? What happens to volume? Huh? Shirley? You said goes down, didn't you?
Yeah.
Well, speak up.
Yeah.
Goes. No, seriously, speak up. Add to this. So the volumes go down. So as we start to think about, if you looked over, and we'll just say right now, you look over at your ventilator, what's your tidal volume?
My tidal volume is 300.
Nope. What's your tidal volume?
Oh.
No. It's on the ventilator, but you're looking at your dialed-in volume.
Oh,
not your-
146.
Is that adequate to ventilate this patient?
That is not
That's
accurate.
less than alveolar dead space, right?
Yes.
And we would expect that because our pressure went up, so our tidal volumes went down. What would you do? This simple stuff. Think through it. I mean, just probably on the top of your head. What do you do?
Increase the PEEP.
We could increase volumes with pressure, but let's think about this real quick. What mode of ventilation are we in?
Oh, we can change the pressure control.
No. Let's, because
Okay.
our pressure's
We're in
30.
a volume control.
We are in volume control,
Yes.
but we are not getting the dialed-in volumes. What can we do?
Pressure support.
No, pressure support is a mechanical is a spontaneous
Like a
ventilation
s-
mode.
CPAP,
We can dial up the volumes, right? What other reason would be that could there be a lack of tidal volume delivered? There could be a leak. Or what happens with establishment of a pneumoperitoneum?
Restricted.
And what happens with that?
Decrease your lung space.
What else can happen to that? Functional anatomy, guys. Remember,
atherosclerosis.
maybe a little bit. What else
Talking about
happens?
capacity? Or?
Remember this thing they called it, and I forget what they called that, and you wanted to be above it with the endotracheal tube?
Carina?
The carina, yes, that's the word.
No.
And we established a pneumo, being facetious a little bit, but the carina.
Oh, I see.
And what happens to that tube? Where does it preferentially
So you
go?
want
To
to
the right
listen to
side.
see if you're still.
Right. Maybe you want to listen to that, but if my volumes go down and my pressures go up, could that be a diagnosis of an endobronchial intubation? I would assume so.
Yeah.
So we check to that. Maybe that's a reason. Here's things you're differentially diagnosing, okay? And you did it, and we'll just call that this is, say, you had to go up on your volumes or your pressures, and you finally got an adequate tidal volume. Again, we have the established pneumoperitoneum. Now we've been doing the operation, fast forward for 45 minutes, that gallbladder's out. What are they gonna do after the gallbladder's out?
I guess. So
They're gonna close up,
Close it
right?
up.
Procedure's done. So as they do that, they're going to take out the trocars, they're going to deflate the pneumoperitoneum. Meanwhile, you've been ventilating this patient with higher pressures to get the same volumes. What do you think's gonna happen now that we don't have that? We're not fighting against the pneumoperitoneum. What do you think's gonna happen?
Too much pressure and you could have a barotrauma.
So as pressure goes up and you're not fighting, you're gonna have increased volume, you're gonna have barotrauma. So that's another thing that we're looking at as the anesthesia provider that's going on. As soon as those things are coming out, we better decrease our pressure, our volume, so we don't blow a lung. What happens if you pop a lung? What do you get?
Pneumothorax.
Pneumothorax. How does that show up on there?
You have a desaturation and
So you guys are gonna know all about this coming up. You get my lecture on Monday for this, so that'd be important. Okay, so you're doing that. Go ahead and flatten out the patient. And when I say stuff like that, I'm taking the surgeon's role. Okay. Gallbladder's out. We're going to say we have about 20 minutes left. For this procedure, to make it simple for everyone to know, when we take the gallbladder out, we have about 20 minutes left. This is a time where there's going to be your cue to start emerging that patient from the anesthetic. Okay. I want you to emerge the patient. You're about 20 minutes out. In fact, I'll be a kind surgeon. Hey, Liviu, gallbladder's out. Thanks for flattening the patient. We're going to start closing up. We got about 20 minutes till we'll be done.
So we're just gonna turn my gas off.
So go ahead and emerge that patient.
And,
What are the things he's going to be doing?
um,
He said turn the gas on.
Turn gas off.
No.
No, don't turn the gas off.
Turn the O2, yeah.
And now I'm gonna turn on my off, not off, high my O2, my gas loads. And make sure that he's blowing off all that.
Well, you're blowing it off for him.
I'm blowing off.
Right.
Off.
Real quick, I wish that I add to this. So this is a fine balance right, when we're blowing off this gas, when we're using the ventilator, we can use the mechanical ventilator to blow off the gas, which is what you're doing right now, which is great. But one thing we're going to do for that too, sometimes is because we'll increase the volume and we'll increase the rate, we're going to sacrifice the CO2. CO2, is that important to us as we're emerging a patient? And if so, why?
It is because it helps the patient breathe.
What do you mean by that?
One
Chemoreceptors?
is the-
Drives your exhalation.
Right, so that's the drive, right? in our
Yeah,
chemo.
yes, the breathing.
So we need those to stimulate respirations. Now, would I rather blow off gas with the ventilator or build up CO2 right now?
How, if we're still
You wanna
20
blow- I'll
minutes,
help.
I want to.
I'm gonna help blow off the gas because we can build up CO2 really quickly. Let's talk about this. How? And then you're gonna do it. How do we blow off gas? Or how do we build up CO2?
By not breathing, by having a low respiratory rate,
Low minute ventilation,
low minute ventilation.
right? So we'll decrease our rate and our volumes once we have blown off the gas. But we'll say we're blowing off gas for 10, 15 minutes, or as they're closing up, right? We said about 20 minutes. So you're properly doing that. We know that we're gonna get CO2 back when we lower the rate and the volumes in a little bit. Take about 2 minutes probably. What are some other things that we're gonna do? So that's going on. What are other things we're gonna be doing right now? Think about your whole PACU, things that you're gonna be going there and backtrack. Think about your intubation, or your whole thing from induction, intubation to maintenance. Now backtrack, get there. What are things that you need to be doing? We talked about some of this already. You're blowing off gas.
Pain, antiemetics.
Pain, antiemetics. What else?
Pain, antiemetics.
Go ahead, Carl.
Reversal for the
Reversal.
neuromuscular block.
Well, that's like
Keep an eye on vital signs to make sure when I get too tachycardic, it like kind of goes wrong.
Pain, PONV, reversal. What else? Oh, that would be important. Oh, okay. Right.
Would you be able to change the vent setting to SIMV?
Good. Good.
Or
This one
in a
has
little lower rate?
the rate. Yes, absolutely. Not every place has it.
Okay.
I refrain. I've done this before. I think it's too many details for you guys at this point. I'd rather just learn the basics. But you absolutely can. Get your mask up there. So talk to me about some of those things we just talked about, Liviu. You're doing great. Talk to me about some of those things.
I want to make sure that my patient's vitals are fine.
Are they fine?
Then
Are they fine? Carl, are his vital signs fine?
Looks good.
I think they're good. Jen, okay, next.
yes.
You got.
I want to get my my tools ready. So
Do you
I
have your
my,
tools ready?
Things ready. I have my OPA and I want to have my suction. Make sure
Have you
that it's
suctioned it?
working, and make sure it's working. I'm gonna.
You're good on that. We already established you're going to let that blow off gas for a while, so we don't need to touch that.
Oh wow.
Help out. Come on.
Did we already give all the medication?
I didn't hear it.
Okay.
Oh,
Yeah.
I thought. Okay, sorry. Then this is what I was gonna do. Sorry. Give him the
What?
reversal medication.
How much?
Okay.
How much?
Check
How
your,
many
check,
kilograms?
check your twitches.
Oh, we better probably find that out.
What did you say?
Check your twitches.
Yes.
Yes. Who likes this? Why don't you like this,
actually,
Carl?
no, that should be here.
You better phone Fred.
I need to
You
think.
better have Carl on your favorite.
Okay.
And what would your response be that you are looking at right now?
I should see the other policies
What does that mean? I don't know.
twitching. You mean the thumb?
Okay.
So I should see some twitching.
So what are you doing right now?
24.
Okay.
Mm-hmm.
You have 1 out of 4 twitches.
I'm gonna wait maybe another a minute or two.
Anybody
See if
else
I
waiting?
Get to
You're waiting.
Depending on what reversal
You don't
agent
know.
have.
I I know that they say 1 to 2
It's
twitches.
no reversal agent.
So hang on.
For sure.
Yes.
Well, we're gonna use what?
Yes,
Neostigmine.
Okay.
So you're gonna wait. You're gonna wait.
I'll wait
You're
for
in-
second twitch.
So you're gonna wait.
I'll wait for the second twitch.
Why are you guys waiting for the second twitch?
Hyun said 1 is okay, but 2 is preferred.
Okay. What did your textbook say?
1 to 2.
Same thing. 1 to
No, it
2.
did say 1, 2, 2. What's the dose for one twitch?
The full 5 milligram.
Okay, what's the mg per kilo dose? You're gonna know all of these.
It's 0.06 or 0.03 to 0.08.
Where is
Max
it?
5 milligrams.
Okay.
How many kilos is the patient?
85 kilo.
85.
85. It's 5.6, 5.7,
It is.
5 it is.
Yeah, 5
Is
years.
that all? Probably not if I just asked. Is that
You got it next with atropine.
Yeah, so.
Atropine?
Oh, sorry.
Glycoprolate.
Glycoparylate.
Yeah.
0.2 milligrams.
Yeah.
You better
Per-
watch this video
per
2 or
per
3
1
times.
milligram.
Richard. Better have this on a podcast. All right. You're gonna give what?
Glycoprolate.
How much?
0.2 per mil.
That's what it is. How much are you gonna give?
How many mils? That's gonna be 5.
How did you get to 5? No, I got that. And that's 1. But how did you get that you're gonna give 5 mLs?
Because it's 1-to-1.
Okay, 1 to 1, that's fine. There's also a dose based upon weight for that too, right?
That one. Yeah, I don't think
It's
I
on your
read
sheet.
that.
You should know this. This is board type questions. Okay.
Yes.
You can do a 1 to 1, but know the dose, mgs per kg or mic per kg for every single drug that you're going to talk about. There's no excuse to not know it. Absolutely zero.
Yes.
0. So we're going to say you're going to give 5 and 5, 5 cc's of both, 5 milligrams and 1 milligram. You happy? Is that it? Ready to wake the patient up?
No.
Carl?
If he's waking up yet.
Okay.
No.
Carl
I'm
doesn't
still
even
going-
know. Who else knows? So what else are you guys going to do?
I'm gonna give my.
Assess for
PO
pain.
Shirley, what are we going to do?
I mean, you just give reverse.
I know. What else are we going to do?
Oh.
What are the things we covered, guys, at the beginning? Think through. You got it. This isn't
PO&B.
PO and B. Okay, talk to me.
Okay. So I'm gonna give 4 milligrams of Zofran.
So I think that's great.
Yes.
And then pragmatically, do you think Zofran should go on before maybe we give anticholinesterase? 'Cause I think anticholinesterases, don't those make you nauseous?
Yes. That's correct.
It's not wrong that you did it opposite
So-
here, but just think about that
Yes.
clinically. Why don't you prophylax against something, right? So you did give Zofran.
Zofran.
So we've given Zofran 4 milligrams. We've given neostigmine 5 milligrams. We've given Robenal 1 milligram. What else have we given? That's it?
That's it.
Do we need pain yet? Let's talk
We need to assess it first.
I,
So,
yeah, then
Does he look in pain right now?
no.
This guy had how many mics of fentanyl up front? Nope. He had 250. I gave 150. I gave the break. He came in here. He was in sizing, and he gave 100. So he's at 250. Does he need any fentanyl right now? Looks pretty good. I don't think he needs any. Do you think he needs any?
I don't.
I agree with you. Okay. So what else are we doing? Go over everything we did again. We're blowing off gas. We've put in the oral airway. We've suctioned the oral pharynx. We've got all of our supplies up there. We've given our antagonist for the muscle relaxant. We've given our PONV prophylaxis. What's the next thing we're going to do? What are we waiting for next? Not all at once, please.
For patient to,
Tell me some things you're thinking about.
you're looking for signs of patient waking up.
I want to see that maybe I see a curare notch.
Okay?
Spontaneous though.
Spontaneous
Okay.
ventilation, trying to breathe on his own.
So let me make this a little more real.
Change my settings to maybe pressure support if I see.
So you're on the right track. You're looking for spontaneously ventilating patient. But we're not sure if the patient is breathing back. You hear an alarm in the background going on. And you look at the alarm and you analyze what that alarm says. And what does the alarm tell you is going on?
So
The end-tidal CO2 is
It's what?
decreasing.
this is
We'll
low,
just
so
call
that
it low.
means
It's
this-
been low. Why is it low? because we've been overventilating the patient to blow off the gas. So do we think the patient's going to spontaneously ventilate with a low carbon dioxide level?
No.
So if we want to increase the tension inside of the serum of carbon dioxide, how would we go about doing so?
We decrease the flows and
Respiration
Your
rate.
flows and
respiratory
have
rate.
but your rate and your volume. So go ahead and you can do that. What I like to do for this on a patient like our size is I take down the volume and the rate to 4. I do 4 and 400. Okay? I would take the rate down here to 400 and you can go 200 if you want here. Okay? And how long are we going to wait for that CO2 to build up?
About 3 minutes.
Okay, sure. 2 or 3 minutes. What's another thing we're going to be doing? So we're going to be looking for spontaneously ventilation. What's another thing we want to assess? Anything we want to assess?
That his train of 4 has gotten better.
You want to do that until you want to wait till he opens his eyes though?
No, I do not.
Okay.
So I'm gonna check that train of 4.
4 out of 4.
Okay.
Ready to be activated?
It could be up to about 70.
What would you want to do?
I will do a tetany to see if there's a sustained.
What would be the level? What would be the stimulus
either
amount?
50 or
50.
100 hertz.
100 hertz.
5 seconds.
Is the patient able to be stimulated with tetany right now? Eyes are still closed.
Probably.
Not probably. The longer you wait, that answer is going to be no. Oh. If the eyes are closed, it doesn't look like he's initiating any respirations yet. Probably a good idea to do the tetany now.
Okay. 100.
And he's holding tetany.
Okay. 5 seconds.
Oh yeah, he's holding it.
I see my.
Now your alarm is going off, and it has been going off. You could have silenced that, looking for a new alarm. So what's some things he could be asking? What's some things you guys are curious about right now, wanting to know?
See if you can actually open his eyes.
Patient is now spontaneously breathing.
Breathing. He's spontaneously breathing. He's a rabbit, folks. You said breathing. Never mind. Spontaneously breathing. I know what you meant. Okay. I haven't heard this yet. End-tidal SIVO. What's my end title? Do we have any gas? Point 2 is your answer because you asked me.
Okay. Point 2.
So you see those things. You think he's spontaneously breathing, right? Those things I'm talking about, the CO2 tracing. What would you do? Anybody, help me. Okay, I'll help you. If I think the patient is spontaneously breathing or over-breathing an event, I pull them off of the mechanical ventilator to see if they are. So I would pull them off of the mechanical ventilator. Lower your flow. Go ahead and lower your flows down to. There you go. And let's see if he's breathing.
Do you do APL on this one yet, or just leave
Do you guys use APO? You know this.
Not.
Do you use APO?
If you're gonna back.
Only if you get it back in.
You guys know this.
So answer is no.
Why is it no?
So you have to breathe against it right now. I'm just trying to
Because
see
he's a
if it's initiated.
spontaneously breathing patient.
Yeah.
Does spontaneously breathing patients require negative or positive pressure? Negative pressure.
Negative, yeah.
So we don't want to add any positive pressure to the circuit. So no. We answered that ourselves.
Yes.
Are you happy? Ready to activate the patient?
See if you can follow me.
He's breathing fast right now.
He is breathing fast. You know, I'm going to take this down because we already said he's not going to get any narcotics since he had 250. Had you not given 100 mites and he only had 150 and you saw that regular respiratory pattern right now at 25, it would probably warrant 50. Okay? But we'll say that he's breathing. I'm going to take him down to 50. Okay? At this point is where you're going to start talking to your patients. I would suction the oral pharynx again. I would be, and then what I'm looking for here is I've already, let's go through this, okay? I went through 4 out of 4 sustained tetany. I have no gas or 0.1 of gas on board. He's fully reversed, okay? We just established that. He's breathing at a great rate. I want to know his tidal volumes. So you would ask me, what are his tidal volumes? His tidal volumes will say are 600. Is 600 an adequate tidal volume? It's decent, right? At a good rate. So is he meeting the criteria to be extubated? Getting real close. What else does he need to do?
Open eyes.
Open eyes. You know, is there a lot of stimulation going on? We'll say the bandage has been on for 2 or 3 minutes. Is there a lot of stimulation going on?
No.
What could we do if we want to?
I can call his name and see.
Call
can
his
you
name.
open his- Carlos, can you open your eyes? Thank you. Can you raise up your head?
And he's raising his head.
Okay. For 5 seconds.
He's kind of shaking his head back and forth.
Squeeze my hand. Raise up your leg.
Coughing.
Huh?
Is it coughing?
Yeah, sure, he's coughing.
Okay.
He's really coughing, fighting, moving.
That's
so
it. Hit you.
If it's coughing,
He's starting to get tachycardic.
Um,
Really getting tachycardic, coughing, shaking his head.
So
Now the nurse,
he
a little
wants his
4'2"
tube out.
nurse is coming over here, and he's trying to fight that nurse.
he
right
wants his tube out now.
Okay. She's really having to hold him down. He's moving now. He's trying to hit you.
Okay.
Which, you know, the more we talk, the more he's getting more violent.
Oh.
Yeah, he's really upset now. He's trying to bite through that thing. He's probably going to break his teeth on that oral airway. He's kicking his legs right now. Oh, he's fighting. You got this on video? Great. Oh, man. He's so pissed right now. Everything was good
I know.
on this part.
Until you woke up and saw me.
You know, the reality is, I mean, most of the time they're not going to wake up that, especially if they were already asleep, they're not going to wake up that violent. Your younger patients, your younger males will wake up violent, typically. Your younger females, they're going to cry, okay? So when we think right before, Liviu, you did what you did, I would have had that tape off and everything. So as soon as I get and I know that he's there, I'm pulling that tube out. Go ahead when you're ready.
So, suction. And give him some. Make sure he takes a deep breath without going like that.
Nope, nope.
Just take the whole thing.
How, remember, positive.
Oh yes.
You want me to do it? Show you? Because you never probably seen it, huh?
I haven't practiced.
Let me show you.
this.
Let me do it. You know,
Okay.
let me show you. It'll probably make this a little better. Here's how fast it's gonna go when I extubate this patient. So let's say his eyes are all the way asleep. Here's what I want you to do. I've done everything you've done. I've given my PONV prophylaxis. I've then given my muscle relaxant. I've allowed it to circulate. As soon as I gave that muscle relaxant, reversal, the antagonist, I've then decreased my ventilator, decreased my flows to see if he can initiate respirations. After I've done that, I come over here 2 or 3 minutes. I checked. He has sustained tetany, 4 out of 4 sustained tetany at 100. I then have that tape off. I then have this hooked up onto the pilot cuff. So the next thing I can do is say, Carlos, wake up. And as soon as he opens his eyes, can you lift your head up? He lifts his head up for 5 seconds. I immediately turn this up to 20. I deflate this all the way down. Carlos, take a big deep breath. He initiates inspiration. He's full inspiration. I pull out as I give positive pressure. This is exactly how I do it. I'll set this right there. Carlos, take a big deep breath. What am I looking for, guys?
Spontaneous.
Right here. Do I have end title? Do I have end title? I do have end title. So I can take my PEEP off. I didn't notice there's foggy and misty in the mask. What's my next thing? What's my next
face
thing?
mask.
Face mask. Put your face mask on. Watch it. Simple, right? See how fast that was? I didn't go fast. I mean, that's exactly how fast it's going to be for each one of you guys. Okay. Questions? Questions, Richard?
So after this, for the sake of the test, we're going all the way to the PACU. Is that correct?
This will be where you stop right here.
Okay.
Your PACU, so this is where you're going to stop on your exam. Go ahead and push space bar for me, please. For the sake of the exam, this is where you're going to stop. PACU really, like I said, is making sure that you can take 2 liters of oxygen, that you can stably go there. All PACU is, I don't know if you guys remember or did a transfer on your shadow day, you CRNA or anesthesiologist, but really PACU is pretty much and should be uneventful. I have the patient moved over to the gurney. I take them to the recovery unit. I give report to the nurse. I told you what to give report of, right? And I have my PACU orders. And all of that stuff you can turn in. Care plan, your pre-op, your PACU orders, all of that can be turned in sooner if you'd like. And then all you can do the day of, if you have time in here, you can be filling out the anesthesia record with your vital signs and whatnot. Or you can fill it out afterwards and turn that in before you go. Okay? That's it. Does that make sense? No more questions?
Are you gonna show us how to record the, what do you call it? The anesthesia record sheet? Did we go over
The
it?
anesthesia record? We went over that in class.
Was it?
There's an example of
There's one in your Dropbox, yeah. Pretty simple. I can show you if you need help too. I mean,
No, I'll take a look.
yeah,
it. Can you record it?
on the record. Yeah, yeah, absolutely. Okay, questions? Question? Okay.
Also in the evening, you can have those steps in, so we can start that.
Try to get them done today or tomorrow. Yeah.
I definitely need to improve.
Well, of course. You guys really haven't done this until
Yeah,
now.
we haven't.
So, I mean, don't get all sidetracked. You can